It's next my pleasure to introduce Dr. Stephen Dean, who's a professor at Ohio State University Medical School, and he will talk to us about the differential diagnosis of lymphedema.
All right, differential diagnosis of lymphedema from a disclosure standpoint, really not relevant, so we're not talking about treatment here. So I don't know how many of you read this article, Diagnosis and Treatment of Primary Lymphedema Consensus Document from the IUP 2013. This is a internationally recognized document. Dr. Lee, we see Dr. Rockson is on there. And I didn't read this cover to cover, but one of the seminal conclusions of this article was as follows, that lymphatic failure is responsible for all forms of peripheral edema. Might be thinking that's an interesting concept. And similar sentiments were echoed in this follow-up study by Dr. Rockson as well. Oops, let me go back here. Where they stated that all chronic edema indicates an inadequacy or failure of lymph drainage. So armed with that information, really the title of my talk, I could change it somewhat to what's the differential diagnosis of lower limb lymphedema, since all edema is essentially lymphedema. In order to gain some information on this differential diagnosis, I've undertaken a database review at the Ohio State Physical Therapy Lymphedema Clinic, and we have a very robust practice. It's affiliated with a cancer hospital, 12 certified lymphedema therapists, and I went and looked at the numbers on lower extremity lymphedema from 2012 to 2015, 472 patients. So what do you think the dominant cause of lower extremity lymphedema was at our center? It may surprise you. Secondary Phlebolymphedema was number one at 36%. Number two, cancer and associated therapy at 23%. Number three, various hybrids or variants of phlebolymphedema, such as cancer-associated lymphedema, where patients would develop a DVT and then worsening swelling, so therefore lymphophlebedema. Lipedema in association with phlebolymphedema, and primary lymphedema making up 16%. We had 10% lipedema and lipolymphedema. Most of these were actually lipolymphedemas. I mean, pure lipedema is really not technically edema, it's swelling. Primary lymphedema 8% and 7% were some other interesting etiologies. But the dominant cause, secondary phlebolymphedema. And of course that is discordant with 99% of the articles you read out there that will state, such as e-medicine, in the industrialized world the most common causes of secondary lymphedema are malignancy and its treatment. Yet our results were concordant with Dr. Wade Farrow's article that was published back in 2010. You can see here phlebolymphedema, a common and underdiagnosed and undertreated problem, where he stated the most common form of lymphedema worldwide may be filarial infection, but the most common in the Western world is actually phlebolymphedema. So keeping that in mind, let's end the talk by going over various clinical manifestations of these phlebolymphdemas or various hybrid edemas. So this patient has obvious stasis hyperpigmentation, so it's consistent with chronic venous insufficiency, but they have an unusual shape to their legs. They have fibrosclerotic narrowing of the distal third of their calf, the so-called inverted bowling pin appearance, but they also have very pronounced foot swelling that you would see in lymphedema. So this is a clinically classic case of phlebolymphedema. But keep in mind, it's extremely important that you recognize that foot and toe swelling is not required to make a diagnosis of lower extremity lymphedema, which includes phlebolymphedema. In fact, this patient here with obvious chronic venous insufficiency, fibrotic swelling with the stasis dermatitis, even in the absence of foot swelling, they have associated lymphedema. This patient with the stasis ulceration, even without foot swelling, has associated secondary lymphedema. Now, this concurrence of lymphedema and chronic venous insufficiency is not a new phenomenon. And in fact, if you go back and look at relatively old data from the 90s, utilizing lymphocytographic studies, Hammond and Associates, 1991, 75% of these patients with chronic venous insufficiency had an abnormal lymphocytogram. Wiesleiter study, roughly 80% of patients with CVI had an abnormal lymphocytogram. So it's not new. Now, you may be saying, well, I thought you said all edema was lymphedema. What happened to the 20%? There's a couple of reasons for this, but I would suggest it's probably just a sensitivity issue of the lymphocytograms, not much higher than 80%. And in fact, if you look at contemporary data, here's a 2016 reference looking at lymphatic transport in patients with chronic venous insufficiency and venous leg ulcers. 12 patients with active unilateral venous limb ulcer underwent indocyanine green lymphography of the bilateral lower extremities. All 12 ulcerated limbs had an abnormal study. even in the absence of foot swelling. So don't let the presence or absence of foot swelling negate you from making that diagnosis. Now, I already threw around this term lipedema. I think it's important that we contrast and compare lymphedema versus lipedema because lipedema is not uncommonly misdiagnosed as lymphedema. First of all, foot swelling typically, but as we've seen, not invariably involves, there's a lot of foot swelling, but not invariably in the setting of lymphedema. So there's classic lymphedema, and you contrast that with lipedema where there's typically, but not invariably, sparing of the feet. So marked swelling, but no foot, of the legs, but no foot swelling. And also you'll notice that in lipedema, the swelling is symmetrical. Lymphedema can obviously be unilateral, but when it's bilateral, which you'll see in some of the primary patients, there's usually asymmetry as seen here. And then finally, one thing I want to point out that's a hallmark of lipedema is this abrupt termination of the swelling at the level of the ankle, referred to as the ankle cutoff or ankle cuff sign. And also unique to lipedema is, in addition to the symmetrical fatty swelling, is the trunk is spared. These patients, even if they lose weight, this patient underwent a gastric bypass, their legs never change. But look at this marked discordance between the size of their trunk and their lower extremities, the truncal lower extremity mismatch. Pear-shaped bodies as well. Now, as you recall, 26% of these patients had somewhat of a hybrid limb swelling. I'll give you a couple examples of this. So you've already seen what lipedema looks like, and I'll tell you right offhand, this patient has lipedema. You can see also what you didn't see on the previous slide is patients with lipedema also often have this little focal protuberance of fat along their lateral malleolus. Hopefully you do recognize also that ankle cutoff sign there, but as I previously stated, lipedema typically spares the feet and toes. Yet this patient has some swelling of the feet and toes. So what's going on here? This is actually lipedema with secondary lymphedema. Patients that have long-standing lipedema not uncommonly eventuate in secondary lymphedema, and that made up the preponderance of our hybrid swellings. So this is actually lipolymphedema. So let's look at this and try to figure out what's going on. This patient has a truncal lower extremity mismatch consistent with lipedema, big symmetrically swollen legs. You see the ankle cutoff or ankle cuff sign there. You see a little bit of swelling in the feet, not a lot, but you also have to account for the venous stasis hyperpigmentation. So what are we dealing with here? This is lipedema with secondary phlebolymphedema. Not uncommon to find this in our hybrid cohort. Lipophlebololymphodema. And then finally, this is a great picture of primary lymphedema and chronic venous insufficiency. A couple of unique points. Now, obviously, when you see this, what jumps out are the stasis changes, so that's obvious venous insufficiency, and hopefully the foot swelling is also of interest to you. Now, what's unique about this foot swelling is look how profound that is. These other pictures I showed you of phlebolymphedema, you didn't see this degree of foot swelling, but that's because this is foot swelling that's markedly severe is a primary lymphedema phenotype. So this patient actually had congenital lymphedema and by their early teens had started to develop secondary venous insufficiency as well. And in fact, the concurrence of lymphatic and venous dysfunction has been recognized in a lot of primary lymphedema such as Milroy's disease and lymphedema distichiasis syndrome. So this is primary phlebolymphedema. And then finally, recall there was a 7% of these patients where they were in the other category. This was a patient I saw with lymphedema, and remarkably, they just saw me about their swelling, they referred for swelling, and nobody tended to address why do they have these purplish plaques on their lower extremities. Well, this is Kaposi sarcoma with secondary lymphedema. So in conclusion, if you just remember 4 things from this talk, number 1 would be phlebolymphedema, not cancer and its associated treatment, is the most common cause of secondary lower extremity lymphedema in westernized country. Again, it has nothing to do with upper extremity. We're just talking about lower extremities. And this is what I see on a daily basis, almost. Foot swelling is not required to make a diagnosis of phlebolymphedema. As we see here, that patient clearly has secondary lymphedema. All edema is lymphedema if you go by contemporary thought processes. And finally, hybrid forms of limb swelling are actually quite common. Things are relatively very simple. In fact, if you add on the secondary phlebolymphedema to our hybrid cohort, 62% of all these patients at our clinic actually had 2 or more causes of limb swelling. So it's not often that it's just a very neat case of this is only lymphedema. So thanks for your attention.